Okay, Section 3 or Unit 3, Ethics and Infectious Diseases. I have to say I've struggled a little bit with this unit, partly because there's not a huge amount of philosophy involved. In fact, that's part of the complaint of Michael Selgelid in his essay, Ethics and Infectious Diseases, that bioethics hasn't really concentrated on this topic, and so philosophers haven't really explored all of the issues involved. So a lot of what is in the 3 articles that we read is just describing what's going on. Now, in the 3rd one, which I actually think is probably the most useful and certainly the newest and most directly applicable to the situation we're in right now, the COVID-19 epidemic, that one had a lot of direct policy prescriptions. And it's interesting to look at how many of them have actually been realized, how many of them have been ignored or avoided, and it's also interesting to try to work out the philosophical justification. So I'm going to go over the 3 articles, but I'm going to try and add to them a little by stressing how some of the ideas we've already come across in the earlier units on ethical theory and last units where I stressed autonomy versus paternalism, how many of those ideas can be sort of brought to bear to these topics. All right, so let's start with the Selgelid article. So that's sort of broken up into 2 main sections. The first section is where he argues that the topic of infectious disease is a very important one for bioethics to study. And he says that there are 3 main reasons for this. The first one is the enormous consequences of infectious diseases. So if you look at any bioethics textbook, there are certain topics that are always covered. So for example, abortion or euthanasia or genetics or using embryos for research, the ethics of doing research, of giving some groups placebos and other groups the drug and so on. These are topics that are always covered. But what you don't see, says Selgelid, is talking about infectious diseases, and he says this is amazing given that infectious diseases have a far greater impact on a far greater number of people than any of the topics that actually are discussed in bioethics textbooks. So that's the consequences section, and we'll look at that in a second. Second one is that there are difficult ethical questions involved that are specific to infectious diseases. And the main reason for this, or the main factor that makes infectious diseases particularly challenging or brings up issues that are not really tackled anywhere else, is the fact that, of course, they're infectious, that infectious diseases are contagious. And this means that the behavior of one person doesn't just affect that person. So the issues we tend to stress, and as we saw in the last unit, is we compare the rights of the individual versus the duty or perceived duty of the doctor to care for that individual. So we looked at truth-telling in the last unit, where Collins argued that the doctor should just care about getting the patient well or ensuring that the patient is happy, and sometimes that requires lying to the patient, in other words, ignoring the patient's autonomy. So it's sort of the autonomy of the patient versus the patient's good. Whereas, of course, the extra factor with infectious diseases, it's not just the good of that patient that we're looking at, it's the good of everyone. So where, of course, Mill, who we looked at in the last unit, John Stuart Mill, is very much opposed to paternalism. His harm principle says that you cannot interfere with the freedom of an individual for that individual's good. So the government cannot force an individual to do something for the good of that individual. Of course, this is an adult. We can do that to children. We can force children to go to school for their own good because they are not yet autonomous. They're not yet aware of what is good for them and what isn't. But once you reach adulthood, once you reach the age of reason, the government is not allowed to force you to do something for your own good. But even Mill, of course, in the harm principle says you are allowed to interfere with the liberty of individuals to prevent harm to other individuals, because of course this is a way to ensure liberty for all. So in other words, I'm not, Mill certainly wouldn't say give Jeffrey Dahmer the freedom to kill and eat people because you can't interfere with his freedom. No, absolutely, you can stop him doing that because you've got to respect the freedom of the people that he's going to kill and eat. Mill would probably allow a wide range of the measures we've seen, actually more in places like China and some parts of Europe, where the government has really cracked down on individual liberties and said you can't do this for the good of everyone. In the United States, of course, it's been a different issue. We've seen people storming the Capitol in Lansing. We've seen protests all over the place saying, let us get our hair cut and so on. They're arguing, well, they're not really arguing, but somebody supporting their behavior or attempting to justify their behavior would say that they're advocating for their own autonomy. But of course, even, as I said, even Mill would say if their autonomy causes the death of other people, then I'm sorry, their autonomy can be restricted. So that's the main difficult ethical question for infectious diseases. Concerns the fact that they're contagious and the behavior of the individual doesn't just affect themselves. We're not talking about someone not taking their medicine and therefore harming themselves. We're talking about people killing other people by their behavior. Okay, and the third reason why Selgelid argues that bioethics needs to address infectious diseases is the issue of justice. As he says in a nicely alliterative phrase, pathogens primarily prey on the poor. That is, the people most directly affected by infectious diseases are those already disadvantaged. So it's like rubbing salt in the wound, insult to injury. These people are already poor and suffering, and then they're the ones who tend to be affected by infectious diseases. And of course, we've already seen this in the coronavirus. I know in particular about Britain and the US, and in Britain and the US both, it is minorities of color in particular, and the poor and the homeless, but minorities of color disproportionately, even if you factor in income, have been affected by the coronavirus. The death rates amongst Black and Latinos in the United States and Britons of non-Caucasian Brits have the death rates are just much higher than white Americans or British people. And also, it's the case that this is an issue of justice because it's the government's actions or inactions. It's a systemic issue. It's a social justice issue because it's the actions of governments that are directly contributing to these bad outcomes for the poor and minority communities, whether or not the government enforces certain things. For example, to pick one case, President Trump has been criticized for not using a power that he has, which is the War Powers Act. He has stressed that he has this power, but he has used it only twice to my knowledge. This enables him to sort of force manufacturers to manufacture things. It was used in World War II, for example, to get companies that otherwise built peacetime durable goods to make weaponry for the war effort. So, for example, there are rifles that are made by Frigidaire because during the war the president said, you're going to stop making refrigerators, you're going to make rifles because we're running out of rifles. So that's a power, an emergency power that the president has. And the president used it with Ford, I think, to make ventilators. But then the second time he invoked it was to force meat processing plants to stay open because apparently we're running short of meat. Is this really the biggest emergency? And of course, what this means is, and actually another thing that President and the President's allies in Congress have been trying to do is protect meat processing facilities from lawsuits from their workers. So what this has in effect meant is that people who work in meat processing plants are being forced to work, and if they stop work, then they're being regarded as someone who has left work voluntarily, and if you leave work voluntarily, you can't be paid, you don't get unemployment. So most workers have been sent home and can apply for unemployment because of it's not their fault that they're not working, because businesses have closed, and even if they wanted to work, they couldn't. Whereas this meat processing these meat processing facilities are being forced to stay open. So therefore, if workers don't go there, they don't get unemployment. And of course, people who work at meat processing plants are typically the poor and the immigrant. And there have been huge outbreaks of coronavirus at these meat processing plants. So of course, if I was someone who was working there, I would want to stay home and say, look, it's not safe. If you force me to go to work, I may die. And yet they're being forced to go to work. So this is a case where a direct action by the government, by the president in this case, but he's part of the government, is threatening the poor, certain communities, the people who have to work for meat processing plants. Working for a meat processing plant, I don't think is anyone's first choice of a job. It's a job you take because it's available and there's nothing else that pays equivalent. So the people who tend to work there tend to be largely immigrant communities. So these are the three issues of why Selgelid argues that ethics and infectious diseases should be concentrated on by bioethics. I skipped over some of the stats from consequences, but they're all about the death rate. So for example, the Black Death killed a third of the population of Europe in 3 years, 1347 to 1350. In the 1918 flu epidemic that we're hearing a lot about because it was the last flu epidemic. Actually, it wasn't the last flu epidemic. There was one in 1957, but it was the last one that really affected the United States. And it's called the Spanish flu for stupid reasons. It didn't originate in Spain. It's just that most countries refused to acknowledge that there was this flu epidemic, which is why so many people died in America, is because the government suppressed information about this epidemic going on, and so people went to these huge, of course 1918 is the end of World War I, and there were huge rallies for the returning troops, and people went out to giant festivities, and these were hotbeds of infection, and people died at a huge rate. Whereas in Spain, they actually said, hey, hang on, there's this epidemic going on, we better do something about it. So Spain was one of the countries that acknowledged it, and it got labeled the Spanish flu epidemic because they were the first people to speak up about it, but it didn't originate in Spain. 20 to 100 million people. Now, why don't we know exactly? Well, we don't know how many people have died of COVID-19. There are all these studies that show that the death rates in states have gone up much more than the normal death rates plus the official figures for COVID-19 dates. So there are these extra deaths that are unexplained. Why is it that more people are dying than usual, even if we take into account COVID-19? A lot of people are suggesting that these deaths might be deaths. I mean, even if they're deaths from things like cancer, then they might be as a result of the measures to fight COVID-19, because, or they might be as a result of the fact that our healthcare system is overtaxed. There's no beds for people. For example, people who are in the middle of getting chemotherapy for their cancer, a lot of those, it's been hard, it's been risky for them to go in and get it, and sometimes doctors advise against it because, of course, they're immunocompromised, and if they go into a hospital to get their chemo, they could catch COVID-19 and they're much more likely to die of it. So, you know, maybe some of the deaths are because the health system has been overtaxed, particularly in places like New York. But it might be also that a lot of people are just too scared to go into the hospital. They don't want to go into the hospital because they're afraid to catch it, and they stay home and they just die. So anyway, 20 to 100 million people died in 1918 of the flu epidemic, and the historian Alfred Crosby said it killed that the number of deaths for a period of similar duration in world history, that's the most. No other disease in a similar time period killed that many people. Smallpox. Apparently smallpox has killed more people in history. More people have died of smallpox than any other disease when you look into history. In the 20th century alone, 300 to 540 million people died of smallpox. And of course smallpox is one of the great successes of medicine, that it was eradicated, except of course the Soviet Union kept huge supplies of it to possibly use as a chemical weapon, and we don't know what happened to most of those supplies after the collapse of the Soviet Union. It used to be, now there is a vaccine against it, but of course most people have grown up not getting that vaccine because smallpox has been eradicated. HIV/AIDS killed 20 million in 24 years, and there are HIV prevalence rates of above 30% in adults in sub-Saharan Africa. Tuberculosis, every year 2 to 3 million people die of TB. A third of the world's population is infected with the latent form. That doesn't mean you have TB, but that means you could get TB very easily. And of course, as we see in the second article we're looking at, TB is particularly worrisome because it's one of the diseases that has developed a drug-resistant form, a multi-drug resistant form. It's a superbug. So if you get that kind of TB, you can't even be treated because or it's resistant to all the major drugs. And then there was SARS. SARS didn't really affect the United States. There was a scare about it, but it affected China, and it affected actually Canada. There was a huge outbreak in Toronto. And SARS was, if anything, much scarier than COVID-19 because the death rate was much higher. The death rate was estimated to be up to 55% in people 60 and older. Now I know that doesn't affect you guys, but it's getting pretty close to affecting me. So these are all serious diseases and with serious consequences. So why aren't philosophers writing about them? Well, that's the second part of Selgelid's article. So the first part says this bioethics should be concerned with this, and then the second part is why isn't bioethics concerned with this? What are the reasons why bioethicists have not written on this topic? Of course, there's going to be a huge explosion of writing on this topic. And as we can see, I just did a search in a academic articles directory for recent articles on COVID-19, and I found the one that is the third article in your readings this week. So there's going to be a flurry of those, you can bet. And why? Because it suddenly affected us. It suddenly affected us, whereas previously we didn't have to care about, things like smallpox or TB, AIDS. You'd think there would have been there were a lot of articles about AIDS when the AIDS crisis was at its peak, before the antiretroviral therapy had been developed. Okay, so what's Selgelid's what are the reasons he thinks that bioethics hasn't concerned itself with these issues? Well, he has 6 reasons. The first of which is that bioethics really emerged as a topic in the 70s. And in fact, Peter Singer is one of the main figures who helped it to emerge. There are a few. Peter Singer is particularly important. A guy called Alan Buchanan is another one. But before that time, there wasn't a specific field of bioethics or medical ethics that was done by philosophers. Now there was sort of medical ethics done by the profession of medicine, which basically was discussions about, should you lie to your patients? Yes, you should. That kind of thing, or the kind of thing you would learn in med school. You shouldn't do this, you should do that. So it was sort of ethical guidelines, but it wasn't a discussion using philosophical techniques of particular issues. That emerged in the 70s, around the time, or after, in the second half of the 20th century, certainly, around the time when there was a huge explosion in high-tech medicine, when we were learning how to do test. IVF, for example, was taking off at that time. So all of these new techniques for medicine were being discovered, and of course there were all these questions, ethical questions about, should we do it? Like cloning might be possible. Should we do cloning? Should we do IVF? Is that playing God? These kind of things. So bioethics sort of grew up alongside this explosion, so it tended to be caught up with those particular issues raised by this new wave of innovation. And of course that's nothing to do with things that have been going on since time immemorial, like infectious diseases. And sort of reason number 2, which is tied up with this, the successes that medicine was having, like eradicating smallpox, like coming up with vaccines, that caused great optimism that infectious diseases would not really be an issue for very long, that we would find, because we got rid of smallpox, we would be able to get rid of everything. Incidentally, one piece of good news that has come out during the coronavirus is they've discovered something that blocks the transmission of malaria in mosquitoes. And that might be an enormous stride forward in eradicating malaria, which is an infectious disease that kills millions of people, and that is not mentioned in the list that Selgelid gives. But that was a discovery that sort of, like the fact that there are UFOs, these kind of amazing news items get swept away in the flood of coronavirus news. Yeah, check out those videos of UFOs if you don't know what I'm talking about. Just Google it. So optimism in medicine meant that bioethics said, oh, if there's no point in focus on infectious diseases, because there won't be dangerous infectious diseases for much longer. We'll sort them out. We've knocked out a couple. The rest will follow in short order. Of course, that hasn't happened yet. Number 3 is the other. That is, that there's a darker reason that that ethicists haven't focused on infectious diseases. It's because ethicists tend to be from wealthy, predominantly white countries, and the issues that of infectious diseases don't tend to really affect them or people like them. You know, I'm unlikely to die of malaria. I'm very unlikely to die of smallpox. You know, and even people who got HIV now notice how quickly antiretroviral therapy was developed when it was finally acknowledged that HIV was an issue. So of the major diseases, I'm not likely to die of them. And I'm the kind of person who's likely to be doing bioethics. And of course, this is why this is tied in with the reason that Selgelid said that this is an important issue, because it's an issue of justice, that the people who suffer from infectious diseases are the people who are already worse off. Now, there's another aspect to the other. This is not directly related to Selgelid's argument, because he's talking about why bioethicists haven't really cared about this. But this comes up in the other articles. It's that once there is a group of people, and by the other we mean minorities or people not like us, and us being the predominantly white middle class bioethicists. When we talk about the other, there is a sad history of victim blaming. That is, because these people are not like us, we can say that we can justify our not concerning ourselves with the things that are afflicting them by saying, well, they must be partly their fault. Notice, why is it that we're not affected? Must be that they're doing something wrong. And actually, to tie it back to what I was talking about, meat processing plants, Tyson chicken, when this huge explosion of coronavirus infections at a Tyson plant was reported, Tyson chicken said, oh, it's nothing to do with us. It's not our fault. It's the fault of the workforce. You know, their culture means that they are not, you know, following guidelines, implying that these people, obviously minorities and immigrants, tend to crush together and in, you know, multi-generational households and don't practice hygiene. These kind of things. There was heavily laden implications that it's their fault, and therefore, you know, you shouldn't blame us for what's happened at our meat processing plant. And that's sadly common. It's victim blaming. Complexity. This is the fourth reason that Selgelid says bioethics hasn't concerned itself with these issues. And what he means by this is that doing justice to issues in bioethics requires a kind of broad knowledge that sadly a lot of bioethicists don't have. My training, for example, is just in philosophy. I never went to med school. When I talk about medical issues, I have to learn up about them. But a true, you know, bioethics specialist, someone who would be attached to a medical school or something like that, they would have to have, ideally, degrees, not just in philosophy, but in medicine. Now, it tends to be that people are experts in one or the other. You get a philosophical article where the person is clearly expert on philosophy, where possibly the knowledge of the medical issue is, well, even if it's not inadequate, it's likely to be very narrow. The philosopher will have learned about that issue, but won't know this huge background in medicine that might help to get a fuller picture of this particular issue. Or you get someone from medicine who just is not really familiar with the philosophy involved. For example, I think the third article that I assigned for you, actually the second and third, the one about XDR-TB in South Africa and the one about COVID-19. Both of those, I think, are written predominantly by medical experts. So they know a great deal about the medicine and actually the social issues, but they don't really touch on the philosophy. They don't say that. They wouldn't be able to say, you know, Kant would say this, but Mill would say this, and whereas Bentham would say this, you know. They tend not to want to get into philosophical arguments, whereas ideally bioethics would combine those two. And there's this added extra feature in infectious diseases, is that you should, because of the justice issue and because so much of the problems of infectious diseases are structural and institutional, because it is a disease that affects the poor, and because policies of government can directly affect whether it is stamped out, as we've seen in New Zealand, or whether it continues to flourish, as we see in the United States and Britain, that's on the government. So you need to have expertise in government and basically sociology. So you need to have 3 advanced degrees to do justice to this, and it's just not that many people who have that wide range of expertise. So that's reason number 4. Reason number 5 is sort of the flip side of this, and some of this is that it seemed like these aren't really dilemmas. One of the reasons that explains issues that really bioethics focuses on is when you have 2 diametrically opposed camps. When you have, for example, abortion. Abortion is an obvious case, where you have on one side saying all abortion is murder, and on the other side saying abortion is just a medical procedure, it's a woman's choice, and if you prevent it, you're restricting her autonomy. So totally opposed camps. That's an issue where, you know, there's really stuff to work with. You can say, well, let's see if we can argue for this side, or you can argue for this side. And there's people who are strongly motivated to argue for each side because there's an opponent to argue against. Whereas in infectious diseases, who's going to argue in favor of COVID-19? You know, let me speak out for COVID-19. It's got a bad rap. I mean, live and let live. Why shouldn't COVID-19 be allowed to flourish? You know, you shouldn't take such a human-centered view. Nobody's going to say that. So consequently, people don't see this as an area where they really need to go in, because they'll be preaching to the choir. You know, if they come out and say, here's my argument for why epidemics of infectious diseases are bad. You know, it's like, no shit, Sherlock. What's the point? So that tends to be why people don't really get into that. But of course, as we've seen in the previous point, really there are a lot of peripheral points that are very interesting, like looking at, one key dilemma is the fight between the rights of the individual and the good of the community. This is the number one issue. I think most bioethicists side obviously with the good of the community, and they, I think, like, well, the majority of people, if polls are to be believed, look at people storming Lansing Capitol not wearing masks, or, you know, just flagrantly disregarding social distancing. They look at these people as crazy. So there isn't really any philosopher sort of defending their view. But I think somebody could make a case that, look, if I value my right to do as I choose more than my life itself, then there's something to be said for that. But of course, I still don't get to hurt other people. So that was the perceived obviousness. And then the 6th point is sort of related, religious hijacking. That is, what he means by that is one of the reasons why topics like abortion, stem cell therapy, euthanasia are such hot topics in philosophy is because you have this religious camp arguing for a position that is very strict, like no abortion, no stem cell therapy, no euthanasia, that seems opposed to what a lot of ethical theories think is the right view. So there's this sort of force in society that bioethicists say, well, if we don't speak up, they're just going to hold sway and bad things are going to happen, and we need to tackle the arguments of this camp. Whereas there isn't, well, actually maybe the explosion of this camp of people saying, you know, it's a hoax and, you know, it's my right not to wear a mask. Maybe these kind of people will create, ironically, a flood of bioethicists saying, no, actually you're wrong, and because there's someone to argue against now. We shall see. So that's Selgelid's article. Now he is actually the predominant ethicist on ethics and infectious diseases. So he's going to be busy in the coming months, and probably already is. But that article is not immediately, it's more a sort of meta issue. It's an article about bioethics, and it's not less so directly about the infectious diseases themselves. So that's left to the other two articles. And as I say, those other two articles aren't really philosophical to a great extent. So the first one, which is in your textbook, is the one about XDR-TB in South Africa. Now, XDR-TB is particularly scary. It's even more scary than MDR-TB, which MDR-TB is multiple drug-resistant tuberculosis. XDR-TB is multiple drug resistance plus resistance to these second-line agents. Okay, so MDR-TB is when you're resistant to the main drugs that are used to treat TB. If you have TB, they will treat you with rifampicin and isoniazid. Where do they come up with these names? Actually, I read somewhere that there is this agency of basically two people who make up these names. That's their job. The drug companies say, we've got this new drug, give us a name. And they sort of have this random generator of syllables, and they make up names. It's kind of like, must be the same thing that Toyota has for naming its cars. You know, what the hell is a Tercel or a Corolla? Well, they just invent these names. Well, somebody invents these names for drugs. So the main TB drugs are rifampicin, I don't know, and isoniazid. So if you have TB, they'll treat you with those. But if you have MDR-TB, those don't work. So they fall back on older drugs that have worse side effects, but that haven't been used in a number of years. So consequently, the bacteria that were resistant to those have died out. And those would be, I don't see the name of the second line agents here, but if they're resistant, if you have MDR-TB, you're treated with those. It's not as good because the new drugs are much better and they have fewer side effects, but it's better than nothing. Whereas XDR-TB, even at least 3 of those do not work. Your XDR-TB is resistant to not just the first line, the best drugs, but also 3 of the backup drugs. Okay, there was an outbreak. Thankfully, this seems to have been fairly localized. If you look up XDR-TB, it talks about this outbreak in 2006, I think, as being the main outbreak. So this article was written when there was danger of this sort of spreading worldwide, and as far as we know, I don't think it did, but there's always the risk. Where 52 of the 53 people, their median survival for 52 of the 53 people was 16 days. So after you were diagnosed with this, of the 52 that died, the the most common, is that the median? Yeah, the most common, or is that it's the middle? Yeah, basically, if you lined up all their life expectancies, 16 would be in the middle, 16 days. So that's pretty terrible. And you can see why this would be terrifying. People just dying of this with no possibility of treating them. Now, they suggest, the authors of this article, Singh, Upshur, and Padayatchi, suggest that as factors fueling the outbreak, inappropriate treatment regimens, that is, they were given the wrong drugs, they were given the wrong dosage, they were given the wrong duration. Factors, sort of external factors, that is, the drug supply dried up, they couldn't give them the right drugs, or the people administering the drugs were incompetent, they were untrained, they did it wrong. There could be patient factors, that is, they were given these drugs and said, you've got to take them at this rate, and they just didn't. Lack of infection control in institutions, and also the South African government policy. For example, those hospitalized at state expense lose their social welfare benefits. So that is a huge disincentive to stay hospitalized, because if you stay hospitalized, you're not getting welfare benefits, and you may starve. So you're more likely to want to leave hospital, and of course then you'll spread it. He said they argue that there is a need to reinforce DOTS, which stands for Directly Observed Treatment, Short Course. That is, they have to be powerful drugs and administered under supervision. And avoid victim blaming. Don't say these people are just dying because they didn't follow the advice. Factors that could undermine the efforts. Well, you need all of these things to detect the drug. To detect the disease. You need the patient to present themselves to the health system. You need a healthcare worker to suspect TB. You need facilities to exist for smears and cultures, and labs equipped for testing. Does this sound familiar? This is the problem we're having with COVID-19, that there just aren't the tests. If we're going to avoid transmission, we have to know who's got it. This is the way that, for example, South Korea, which had its first recorded case on the same day that the United States had theirs, and is a modern industrialized nation like the United States, and it's a lot closer to China, this is how they were able to control it much more successfully than we have, if we've controlled it at all, was by just doing blitzing with tests, by testing. Actually, I put on the webpage a Twitter thread of someone who visited South Korea that gave you some idea of exactly what they're doing. And it's worth reading because it's pretty intense. You know, when you arrive, you're put into quarantine, you're testing, you're forced to be tested, you're tested regularly. They made sure that there were enough tests. That was one of the things that we bungled, that we didn't accept tests from outside because we thought we'd got one, and then there were problems with the test, so we never had, and we still don't have enough tests. I don't know, if you just want to get tested, if you're worried, you don't know you got it, you got a sore throat, you can't get tested because they're reserving the test for people who are seriously ill. Whereas if we're going to control this, you need to test everybody, because people can be asymptomatic carriers. We've learned that you can show no symptoms and still be someone who could infect somebody else. And so what they did in South Korea was they tested everybody, and if you tested positive, first of all they confined you, but also they did contact tracing. That is, they would find out the people you've been in contact with, and they test them, and then they trace the tree back, which is pretty tough to do, but that's what they're trying to do. So we need, not only do we need lots of tests, we need contact tracers. We need hundreds and hundreds of these people who will sort of do a detective mission on seeing who you've been in contact with. And of course, these are things that poor nations can't do. This is the worry. COVID-19 hasn't really hit really poor nations in Africa yet. And if it does, they're just not going to be able to do the things that we can do. In India, for example, quarantining might mean death, not just because most people live in very packed in accommodation. They're with lots of people. They can't separate from lots of people. So if one person in a household has it, they can't separate from everybody else. There's nowhere for them to go. And the other thing is, there's a huge number of poor people who literally exist hand to mouth. If they're not earning money on that day, they don't have any money for food, and they will starve. And of course, that's going to be even worse in many countries in Africa. So if it hits Africa, it's really going to cause horrific mortality rates. And in, of course, South Africa is one of the wealthiest African nations, but it also, like most sub-Saharan African countries, has a huge AIDS problem. And in fact, this is where the drug-resistant TB problem is worse, is in people who are HIV positive. But what these authors suggest, that patients with XDR-TB should take precedence over even people with full-blown AIDS because it's so highly infectious. So, in other words, it should mean the case that hospital beds and isolated hospital beds should be given to them first, even if this means pushing people with full-blown AIDS out of a hospital bed. That is, of course, an obvious example of the issue of contagion being a real issue. Another interesting discussion in this article on XDR-TB, not related to the disease, but is to do with HIV, is this case Enghorn versus Sweden, which was a case in the European Court on Human Rights. The person who brought suit, who I'm going to assume is Enghorn, I don't know, was an HIV-infected man who had infected another party and disobeyed the instructions of public health officials to avoid irresponsible behavior. He was given compulsory isolation orders and involuntarily detained in a hospital bed. And he brought suit claiming that this was in breach of the European Convention for the Protection of Human Rights and Fundamental Freedoms, under Article 5.1, which says, everyone has the right to liberty and security of the person. No one shall be deprived of his liberty, save in the following cases and in accordance with the procedure prescribed by law. So he was pointing to the no one shall be deprived of his liberty. Now, of course, one of the later provisions that says that you could be deprived of your liberty was the lawful detention of persons for the prevention of the spreading of infectious diseases. And that's what Sweden claimed justified it. But what the court actually ruled in Enghorn's favor, because the compulsory isolation should only have been considered as a last resort after less severe measures have been considered. Now, presumably what the authorities in Sweden were thinking was, this guy has already been irresponsible. He's not going to follow those. So if we just say don't do it, or we, just give him a strict talking to, he's going to go out and infect people. But he argued that not enough. He wasn't given enough chance to prove that he was responsible. There's also a related principle in South Africa, the Syracuse Principles on the Limitation and Derogation of Provisions in the International Covenant on Civil and Political Rights. That says, public health may be invoked as a ground for limiting certain rights in order to allow a state to take measures dealing with a serious threat to the health of the population or individual members of the population. Now that sounds sensible, but of course if you don't trust your government, that sounds incredibly sinister. That sounds like the beginnings of authoritarianism, that your rights that you value above all can be infringed because of a state of emergency. So consequently, if you have convinced yourself that COVID-19 as an invention or was started by the government, or Bill Gates apparently, I don't know what that's about. Poor guy, he he's a villain in Microsoft, and then he gives up Microsoft and spends all his money on fighting infectious diseases and trying to find cures for infectious diseases in the poorest of countries. And now suddenly he's Mr. Evil and that he's responsible for all this. I don't get it. Anyway, but if you have a severe distrust of your government and you believe that they might try to crush your rights, then you might be suspicious of this kind of measure. You might find this language, that public health may be invoked as a ground for limiting certain rights, as very scary. It goes on, these measures must be specifically aimed at preventing disease or injury or preventing care for the sick and injured. But of course, it's easy to justify something as being for the good of the sick. Now, the authors of this article on XDR-TB state that being infected is not a crime, and that a strong reciprocal obligation is borne by authorities so wishing to invoke these measures. What they mean by that is that if you do invoke these measures, if the government sort of, as it has, as for example in Michigan, the stay-at-home order, then it's on the government to ameliorate the suffering that results. So this is why we got those checks for people were supposed to get checks for $1,200. Well, not that I especially needed it, but our check was much smaller than that. I hope your check was for $1,200 and that you got one. But the point of those was to try and make up for the suffering of not being able to work. So that's what they mean by reciprocal obligation. But they also quote Harrison Home in a 1995 article, who say that all people have a duty not to infect others. Although Harrison Home also goes on to say it is a duty which we can expect people to discharge only if they live in a community that does not leave them with all the burdens involved in discharging this duty. What they mean by that, I presume, is that it's all very well telling homeless people don't infect others, go home and stay home and quarantine, but if they can't, well, then you can't hold it against them. You've got to provide, if you're going to tell people they've got to do this, you've got to make sure that they have the means to do this, which is why the COVID-19 article advocates freeing up hotel rooms for homeless people. And of course, hotels are empty right now because they're not allowed to be used, so why not use them for homeless people? It's interesting that for example, in the UK, there's a footballer, was it Gary Neville, who is famous for playing for Manchester United, which is probably the most famous English football club. And he owned a string of hotels, and the minute the COVID-19 pandemic started, he basically gave over his hotels to use as hospital rooms. He says, if you need extra space, if they've got beds, use these. Now, I'm not sure how useful those are, but a lot of hotel owners did that. One of the people who didn't, of course, is the Trump organization, a famous hotel owner that didn't do that. Okay, summary of the XDR-TB article. All reasonable attempts must be made to accommodate the interests of infected patients in a sensitive and humane manner. So that means trying to respect their rights. Although, if necessary, the government must adopt a more robust approach towards uncooperative patients with MDR-TB and XDR-TB, which might necessitate favoring the interests of the wider public over that of the patient. In other words, we may be able to confine you, as we do with, for example, people we deem insane, dangerously insane. These can be committed. Now, normally we say we commit people for their own good, which is paternalistic and actually even more controversial than committing people for the good of others. But, if somebody is dangerous to other people, I think we say we have all the more reason to confine them. The complication with, of course, insane people is we don't think that they're capable of autonomy. Severely mentally ill people are not autonomous. So then we don't have the issue of autonomy versus public safety because there's no autonomy. Whereas, of course, the cases of these people with MDR-TB and XDR-TB, they are autonomous. They're of sound mind, at least. Although such an approach might interfere with the patient's right to autonomy and will undoubtedly have human rights implications, such measures are reasonable and justifiable and must be seen in a utilitarian perspective. There is the one reference to a philosophical position in this article. And remember utilitarianism from Unit 1, which is the idea that you maximize happiness for all affected, which of course can involve sacrificing the interests or even happiness of individuals if it's for their much greater good. And must be seen in a utilitarian perspective. Ultimately, in such crises, the interests of public health must prevail over the rights of the individual. There you go. So this article comes down on public good trumps individual rights. So the members of those protest groups that are arguing for opening up the states now would hate this article. Let's look at the COVID-19 article by Lawrence Gostin, Eric Friedman, and Sarah Wetter. I'm going to jump ahead to where they quote, the National Academy of Medicine defines crisis standards of care as the optimal level of care that can be delivered during a catastrophic event requiring substantial change in usual healthcare operations. So, the National Academy of Medicine allows that in an emergency we can make big changes to usual healthcare operations. So what are the justified changes? The other thing they stress, is we must not wait until the disease is widely detected in the community. That is something that the governors of Ohio and Michigan in particular took seriously. And certainly the NBA took that seriously. The NBA, of all organizations, they were one of the first to take this seriously. They had one person, Rudy Gobert, who has recovered, of the Utah Jazz, tested positive, and they shut down the season. That was it. Bam. Now, you might say, well, that's just one guy, just quarantine him. But of course, he'd come in contact to all numbers of people, and we don't know, and we didn't know at the time whether or not you could transmit it and not show symptoms, and it turns out you can. So the authors of this article argue that you mustn't wait until the disease is widely detected in the community. Of course, you're taking a big risk, because if it's not widely detected in the community, then people say, this is a fake. Why are you doing this? There's no reason to do this. But of course, as we found out in Michigan afterwards, even with the lockdown, the weeks leading up to that had been the problem, and we've had one of the worst rates in the country, despite the lockdown. It was because of what had been happening before that. So what Gretchen Whitmer would probably say is, think how bad it would have been if we hadn't locked down. If we continued going as we were going. And I mean, like I remember after we closed classes at Flint, I went to the rec center was still open, and I went and there were people playing sweaty basketball games. The gym was packed. And I looked down on them and I thought, what are you doing? Who knows how many of those guys were transmitting it. Now they're younger and healthier, but I'm sure they have relatives who are not. One of the big issues tackled in this article is allocating scarce resources. So what they say is we must protect health workers train them in infection control, supply them with adequate PPE, and provide them with any vaccines. They must be the first to get the vaccines if any are developed. Now, of course, we've seen that was a problem. Adequate PPE was not available in many places. The masks, the N95 masks, they were in short supply. I don't think it's as bad now, but certainly for a while there, it was pretty bad. People were literally wearing, people working with COVID-19 patients were literally wearing bin bags to cover them because there wasn't appropriate gowns and stuff. After that, who is tested and treated after the health workers must be divided according to first, prevention of transmission of virus. That is, we must prioritize resources to people in confined settings and areas with localized outbreaks. So, for example, Seattle had one of the first localized outbreak in that retirement home because somebody went on a cruise and went back to that retirement home. You prioritize resources for something like that. So our first goal is prevention of transmission of the virus. Then protection of individuals of highest risk. Older adults, people with compromised immune systems, people with underlying conditions, diabetes, for example. Third is we must then meet societal needs, so that'll be protecting people like grocery store workers or pizza delivery people, frontline workers who are still, or meat packer, people working in a meat packing facility, for example. And then finally, promoting social justice. So supplies and countermeasures must be distributed equitably with poor and marginalized populations getting their fair share. Now, I imagine that this is controversial in some circles because there are some people, for example, libertarians, who would say the government has no duty to promote social justice, social justice warriors. But what they're arguing is, what they stress, particularly at the very end, is we are only as safe as our most vulnerable, and that it is not just social justice that is the issue here, it is the safety of all. As it says, at a time of vast inequities, we were all only as safe as the most vulnerable among us. So this is something that was stressed by Selgelid of why that justice is an issue in infectious diseases. That where there is great inequality and where there is great poverty, that is a hotbed for transmission of the virus. Wealthy people are doing fine in the COVID-19. At the worst, they're getting bored of what's on Netflix, getting antsy. People going, not having their hair cut, not liking how they look right now. But, in the early days, all these celebrities were putting out these videos saying, shelter in place, like Arnold Schwarzenegger saying, come on everybody, shelter in place, I'm doing it, and he's sitting in his pool smoking a cigar. Yes, of course you're okay sheltering in place, you've got a freaking pool. You're fine, you live in Southern California, you're sunning yourself on your deck. Other people, their apartments are not so great, and they've got young kids who are not going to school driving them crazy. Sure, but some people just literally have no safe place to go. And if we're going to, in a world where infectious diseases are going to be more of an issue, as scientists say there are because of global warming, we need to fight inequities for the good of everyone in society, except maybe the billionaires who literally can go into bunkers and seal up for a year. Maybe they'll be okay, but the rest of us who want to actually go out into the world and interact, if there are places where the infectious disease cannot be contained, then that affects everybody. in society. So that's why the authors argue that we should promote social justice. There should also be a fair process of deliberating. He says must involve the public. Presumably the protesters at Lansing say that that was not followed. But actually they're a fairly small minority, so even if it was, polls show that even if they did involve everybody, they would agree. We'd still be in the same situation. Most people don't want to go back to work yet. They don't feel safe. The deliberation must be made in advance. The deliberation must be transparent. There mustn't be ulterior motives that we don't know about. For example, critics of President Trump say the reason he wants to open the government now is not because it's safe. It's because a bad economy is terrible for his re-election chances. So he wants to make the economy improve a bit so that he'll get re-elected. And so he's motivated by political reasons, not by reasons of safety, which is why, Anthony Fauci is kind of being suppressed. We don't hear we hear Trump when he was still doing these press conferences, and he kept stressing the cure must not be worse than the disease. That's what critics suggest, that there are ulterior motives, that it's not transparent. We need to know, if you're going to say it's safe to reopen or we should reopen, then we need to have studies of what this will affect. There are leaks from the administration that say that actually studies are showing, in all of these states where they're opening up, like Texas and Georgia, I think it was Texas, there was leaked, the governor basically admitted that the death rate is going to spike when they open up, but he's going to do it anyway because got to save the economy, even if it means grandma's going to die. All right, so transparency would allow us to make that decision. Say, look, if we open up here, here's what the projected death rates will be. Now, maybe we as a society decide to say, okay, for example, Sweden hasn't really shut down much at all because they've made the calculation, and Holland has done a similar thing, made a calculation that we'll just let it go through and then we'll develop immunity for the second wave. But they know that what this means is that a lot more people are going to die than would if you shut down and waited for waited for a vaccine. So they made a calculation saying, it was a utilitarian calculation. It said, we're going to sacrifice the people who are going to die who wouldn't have died otherwise, and they're probably older, and they're probably poorer, and they're probably less healthy. Those people, sorry, you're doing it for the good of us. Okay, maybe society makes that decision, but everybody has to be involved, in particular the people it affects. And it must be made on clearly explained rationales. We must say, look, this is why we're doing it. This is the effect of doing this. And it must be based on science directly related to the disease and health outcomes. We must have good science. We must have studies. We can't just say, my gut tells me we'll be okay. The last point they make is allocating scarce resources must not just be local, it must be global. We need to send, as they say, this is a quote from the COVID-19 article, the United States is ethically obligated to assist, even if this means reducing American stockpiles, to maximally protect and equally value all human life. Vitally needed supplies like PPE and, when available, vaccines and treatments must not be hoarded by wealthier countries or the countries where they happen to be manufactured. This is a matter not only of ethics, but also of ensuring Americans' health. So like the point about social justice within a society being for the good of all, making sure that there aren't outbreaks, because there was an outbreak in China and it swept over the world. So if we can do our part to ensure that there aren't outbreaks where things start, like remember the Ebola scare that started in Africa, in a poor nation. So we need to make sure that that doesn't start and then everybody will be safe. So it's in our interests as well to help out poorer nations. Looking at the line where it says, must not be hoarded by wealthier countries. I don't want to sound like I'm just bashing on President Trump, but there was a news story a few weeks ago that when it looked like a vaccine was promising, apparently the Trump administration tried to buy up the entire supply. It was a German company, I think. That's right. It was a German company who had got a promising breakthrough. I don't know what happened to that. But the Trump administration tried to buy up their total supply, and they refused to do it. They said, look, no, we're not going to give it to just the we're not going to give it to the US only. And presumably this is the kind of thing they're talking about. You shouldn't try to just sit on, corner the market on it. It's for the world. It's our duty to share it to the world. Like the discoverer of the person who worked out how to make insulin did not patent it. He said, I can't patent this because it's for the good of humanity. And so made it available. And now, of course, the cost of insulin is spiking because people have decided, no, they want to make money off it. More points made in this article. Protecting the most vulnerable. Testing and care must be available to all, so it must be provided for those who can't afford it. In other words, it shouldn't just be for those whose insurance covers it. Health facilities should be enforcement-free zones for undocumented immigrants. And the reason for this has obvious utilitarian justifications. If you say ICE is going to be waiting at the hospital for undocumented immigrants, they're not going to go to hospitals, which of course means that not just that they're more likely to die of it, but they're going to be out in public not getting treated, and they're going to infect other people. So it will all backfire. Health facilities should have staff members who can communicate with non-English speakers. Again, we've got to treat everybody. Supplies of sanitizer and hygiene kits should be supplied to homeless shelters. Once again, this idea of the most vulnerable. We're only as safe as the most vulnerable among us. Talking about, it's interesting to see all of these suggested policies. That this article was obviously written right as the outbreak was starting. So how much of these were followed? Closing public spaces, yes. Cancelling public events, yes. Even political rallies, they mentioned. Trump had a political rally in March, which was considered a bit late. And of course we had these political rallies at the Capitol that already have been, some COVID-19 infections have been blamed on. You've got to, if you're going to do these kind of things, you have to combat loneliness. There's another crisis that people are saying is following the epidemic, and that's going to be a mental health crisis, because I'm a bit of an introvert myself, so I'm kind of okay with this. Plus I live with my family, so it's not like I'm on my own. I'm kind of okay with this isolation. But people who don't have their families and are lonely and rely on their social networks are suffering at the moment. Ignore my phone. We got to combat blaming the other, and they give specific examples of people of Asian descent who were blamed in the early days or attacked because of the China virus. That was another thing. The Trump administration, Trump in particular, but also his Secretary of State, insisted that it be referred to as the Chinese virus. Now that never caught on. It reminded me of Mean Girls. Stop trying to make fetch happen. They tried to make Obama kept. This also reminded me of when Obama kept referring to ISIS as ISIL. And there were reasons for doing that, but it never caught on. People kept calling them ISIS. And Trump tried to call it the Chinese virus, but nobody calls it that as far as I know. It's the coronavirus or COVID-19. But that's part of placing blame. Now they say it's placing blame on China, but we saw this spike in attacks on people of Asian descent. Blaming the other should be avoided, they say. We've got to meet essential needs like medication, food, and water. There've got to be food deliveries for poor people, particularly kids. There are a lot of poor kids whose main meal of the day was free school lunches, and now they're not at school, so we have to ensure that those are delivered. And that's happening, I've heard, in a lot of neighborhoods that they deliver school lunches, but that has to go on according to these authors. Paid sick leave for people out of work because of quarantining. We saw the issue with the meatpacking plant, of course, that they wouldn't get that if they stayed home because they're supposed to be at work. The authors talk about the social compact. That is, the government and the people, everybody does their part, and it's reciprocal. So the part that we're supposed to do is socially isolate and not go to work. And that causes a lot of suffering, particularly financially. And so the government has to play its part, which is making sure to try and lessen the suffering by giving us these quarantine checks and so on. Ideally a lot more than that, but that was a start. Interesting suggestions for prisons: compassionate release, electronic monitoring, releasing people jailed because they can't pay bail, release those with underlying medical conditions or low risk of offending. There's something in the news this morning on the radio about, in Michigan, there is a law that says, I've forgotten the name of the law, but it says you cannot release anyone ahead unless they've done their full mandatory minimum sentence for that kind of crime. In other states, if you do good time, which is time off for good behavior, if you get a degree in prison, or you don't cause any disciplinary troubles, or you learn a trade in prison, that can count against your sentence and you can get released early. In Michigan, that's not allowed. They have this specific law that's enforced. And the suggestion is that we should get rid of this law because it's preventing us releasing people from prison who are at risk of the coronavirus. There was somebody who died of the coronavirus very early on, who was held in jail, and it turned out was innocent. They hadn't even gone to trial yet. They were being held in jail, and they caught the coronavirus and died. I'm just going to read the last passage on page 11 and 12, or at least the important parts. These are difficult questions, they say. Are complete lockdowns necessary, or may an 80-year-old without underlying conditions go for a short walk outside while practicing physical distancing? Talking to my relatives in Britain, it's amazing how much stricter, even in Britain, which is not that strict, standards are. For example, I may have mentioned before, until today, you were only allowed one walk. And if you got caught and it was on your second walk of the day, you could get a ticket. You could be fined. And the police were fining people. And if you went for a drive and the police pulled you over and you couldn't say where you were going, and it wasn't like to the grocery store or something like that, if you just said, no, I was out for a drive, you could get a ticket for that. This is the kind of enforcement that probably, being Americans, you will find like crazy and draconian. But if we look at the measures, for example, South Korea took to fight it, it's measures of that kind of severity. And the question is, are our rights to go for as many walks as we want worth the rates that we're seeing in the United States? Monitoring and enforcement through surveillance modes, including thermal scanners, electronic bracelets, and web cameras, implicate privacy interests. There's a suggestion for a smartphone app for contact tracing, that if you install this smartphone app, and in China this was required, for example, it knows who you've been in contact with, because it keeps track of where you are and it keeps track of other people. And of course, if you've come near each other, they will not be able to know, oh, that person is a risk of having caught it. If it turns out that you test positive later, they will know all the people that you came in contact with because everybody had this app on their phone and we were able to trace them. Now, of course, if you're at all paranoid, and maybe justifiably so, about authoritarian states, that sounds horrifying. The state knowing where you are at all times and being able to trace everybody you've been in contact with. Imagine how useful that would be to stamp out political dissent. You know, they catch one person who harbors anti-governmental beliefs and they'll be able to see everybody this person came in contact with. But you're fighting an infectious disease. So I think in countries where people have trust in their governments, it's much easier to fight this virus. I think New Zealand is an example of that. In New Zealand, the Premier, Jacinda Ardern, I think it's Prime Minister they have there, not President, is widely popular and seen as someone who hasn't got a hidden agenda. And they have wiped out coronavirus. They had like double-digit at most deaths. It didn't reach 100, I know, far from that. And now, of course, they're an island. It's easy to isolate themselves from the rest of the world. But hey, Britain is an island, and look what's happening there. So I think the fact that New Zealanders had faith in their government, even when they disagree with the government. I mean, it's not like there isn't an opposition party. There absolutely is, and it's been in power fairly recently. But they didn't believe that their government was conspiring against them. And I think that contributed a great deal to people following the guidelines and stamping out the coronavirus. Enlisting armed police and citizen informers to control large populations in cities like New York or Chicago seems so contrary to American values and the rule of law that it is difficult to conceive opting for that route. It is, isn't it? At the time of vast inequities, we are all only as safe as the most vulnerable among us, both in the US and globally. If poor or disadvantaged members of our community cannot practice physical distancing or access health services, then we will all be at greater risk. Equity and public health go hand in hand. That's the other thing. Countries with a robust social welfare and national health system should be doing better. Now, of course, Britain has a national health system and it's struggling, but it is a national health system that has been targeted by the policies of the current government, and that's one of the major criticisms of it, that they have been kind of squeezing it because they're a conservative government and they don't like the idea of the social welfare system. They want to make it as narrow as possible. But the national health system is very beloved in the United Kingdom. You know, if you tried to outright get rid of it, you would be out of government pretty much immediately. Other countries, so for example, Iceland, the Scandinavian countries, Norway and Finland seem to be doing better. Germany is doing very well. That has a very good social welfare and health system. So these countries, that does seem to contribute to battling it well. Equity and public health going hand in hand. All right, that's enough of that.